of surgeries we do from. So I'll just start briefly my slides. The complete urology care that's available in the world that is called MASH, Minimal Access Smart Surgery Hospital. So what are our scope of services? So 50% volume of the patient is of the kidney stones. That include kidney stones, ureteric calculus, vesical calculus, and I do basically all the minimally invasive procedures that is called URS, RIRS, retrograde intrarenal surgery, mini PCNL, the tract size is very small. Supine PCNL has come up in a very big way where you don't need to turn your patients prone to do function in the kidney, and the recent technology is PCRIRS where you combine a supine PCNL with an RIRS. Andrology services, penile implant, that's a routine, that includes a 2-piece implant, a 3-piece implant, varicocele microsurgeries. Regarding oncology services, we have dedicated kidney cancer, bladder cancer, urothelial cancer, penile cancer, and testicular cancer. So all the cancers are treated by a state-of-the-art 3D laparoscopy system by Karl Stores we have available in our OR. So 3D laparoscopy comes in between a standard laparoscopy surgery and a robotic surgery where the surgeon has a 3D visualization of internal organs, and that's very beneficial in operating in deep pelvis. So prostate, which is treated by lasers, that the surgery is called volume enucleation of the prostate, laser Brigham and a bipolar cleaver. Reconstructive urology, I do encounter a lot of kids where there is hypospadias, urethra opens at the ventral aspect of the penis. So that includes in reconstructive surgeries, that's called hypospadia surgery, and 3D laparoscopy, which I have just told, that includes a nephrectomy, radical cystectomy, prostatectomy, and a coloplasty. So I'll just show the videos of few of the selective surgeries, few of the difficult cases. So right now, we're starting with basic surgery that is called semi-rigid URS, ureteroscopy, where we go inside the ureter and lace the calculus with a holmium laser. We have a 60-watt laser with us, it's pretty powerful. And now it depends on the size of the calculus. Many times we are confused. As a physicians, you encounter a lot of patients of calculus disease, whether this patient needs surgery or not. So it does not always depend on the size of the stone. We have to also see the symptoms of the patient for how long the disease or the symptoms have been present. So I basically operated on a 3 mm stone patients where the patient has landed up in ARF because both ureters were blocked, and somehow sometimes 7 to 8 mm stones also spontaneously possible. So it does not always depend on the size of the stone. We have to look at the symptoms. The next surgery is RIRS. We have a chip-on-tip camera that is state-of-the-art, that is 7.5 French flexible ureteroscope that goes inside the kidneys. So up to, I'll say 1.9, 1.8 centimeter calculus, which are located inside the kidneys or renal pelvis. You don't need to puncture the kidneys. Previously, 5 years, 6 years down the line, because the scope size was not miniaturized, people, urologist fraternity used to do a lot of PCNLs. But nowadays, up to 1.5, 1.8 centimeter stones, depending on the Hounsfield units of the stones, we can do RIRS, that is retrograde intrarenal surgery. So I'll just show you some difficult cases. This is, I'm inside the ureter, the stone was lost in the upper ureter. What you just saw was an access sheet that how we gain entry into the kidneys. And this is the stone which I'm lacing with my flexible ureteroscope. The vision you are seeing is a chip-on-tip camera. It's a very good vision. And up to 1.5, 1.8 centimeter, the stone does not need to be retrieved from the kidneys. You completely dust it inside the system only. So that was one of the difficult cases which I have done over here. The stone size was around 2 centimeter. The patient was referred by a forum of gynecologist only. So the patient was counseled about PCNL by 2 or 3 leading urologists, but somehow I managed to do RIRS in this case. You can see the dust, it is just starting, and this dust will completely go to less than a particle size of 0.5 mm. So you can see the degree of impaction here, where the stone was badly impacted in the upper ureter. First we have to dismount it, then push it inside the kidneys and then start lasing it. Stone PCNL has stood the test of the time for managing kidney stones, but from a 30 French tract size going inside the kidneys, now we have miniaturized it to a 10 or 12 French size. So as the tract size is going smaller and smaller, the complications of PCNL are going less. Earlier, when in our training time, when we used to dilate the tract by 24-26 French, the incidence of AV fistula and pseudoaneurysm was around 24%. But when we have a good quality of nephroscope, that is around 10.5 French to 11 French in size, the tract size is around 14 French, the complication rate of PCNL has drastically gone down. So these are some of the difficult cases which I have done. This lady presented with a huge burden of stone on the left side, 5 into 4 centimeter, 3 into 24 centimeter, which was cleared in a single sitting. This gentleman had a stone of around 6 centimeter. His whole kidney was filled with stones, and as you can see, the tract size was around 24 French, but it was managed in a single tract. I didn't need to do a double puncture. Supine PCNL has come up in a very big way, where in prone PCNL, after general anesthesia, the patient is turned prone to puncture the kidneys, and the puncture is a fluoroscopic guided puncture. In supine PCNL, you don't need to turn the patient prone. So you can see I'm puncturing the kidneys right now in lateral position. My initial puncture needle is going inside, and you can see the clear urine coming out. So whenever patient is morbidly obese, whenever there is a risk of turning the patient prone, that can increase the complication. So the preferred modality of treatment is a supine PCNL. So you can fragment the stone by laser or pneumatic lithotripsy, and after this you can see the complete clearance of the stone. ECIRS is a combination of two surgeries, that's called RIRS plus supine PCNL. Whether if the stone burden is huge, for an RIRS, because we don't want to spend a lot of time inside the kidneys when we are gaining the axis retrograde, we do both axis from the antegrade way and retrograde way, so that I'll just show the video to make you understand easier. So I'm visualizing the kidneys from below, and under vision I am puncturing the kidneys in this area. So you can just see my needle is coming inside and the tract is being dilated. So see, this is the needle coming inside, under vision, now we are puncturing the kidney, so that the chances of a false tract or pseudoaneurysm or AV fistula are going to less than 0.1%. You can see the guidewire coming antegradely, and you can visualize this, and you can dilate the tract. The tract has to be directed inside the patella, so that you don't land up in a bleeding complication. So what we are doing here for prostate disease is a Holmian enucleation of the prostate. TURP has stood the test of the time for the last 20-30 years, but nowadays there are n number of studies to label HOLEP as the new gold standard for treating prostate. So we are doing HOLEP here. Here we enucleate the prostate from its prostatic capsule, because we all know prostate has got a capsule and adenoma. Adenoma is the part that is obstructing the flow of urine. in benign prostatic hyperplasia, when we do Holep, we enucleate the lobes of the prostate and push it inside the bladder. You can see this is the laser fiber, 60 watt laser fiber, and we are, first we made incision from right lobe to median lobe to make a crest over there, so that the principle is to enucleate it, imagine it as an orange. So systematically you have to enucleate the orange, leaving the peel in total. And whenever the adenoma is completely enucleated, you just need to morcellate it. That means you have to evacuate that adenoma without doing multiple pieces. So right now I am creating a trough from the bladder neck to the vein montanum from both the sides of the median lobe, because this gentleman had a prostate of around 120 cc, and the first part is to enucleate the median lobe so that your flow of water and everything is good, because the vision has to be clear to enucleate the prostate from the capsule. After enucleating the median lobe, we give apical incision, the prostate lobes just lying around the vein montana, and we give the incision from 6 o'clock to 3 o'clock and from 12 o'clock to 3 o'clock. So in this video, you will see first the median lobe will get enucleated, that is going to be pushed inside the bladder, and on a later hour we morcellate it. So in this surgery, it is very important to distinguish between the capsule and the adenoma, because if somehow a urologist is made, he is bound to perforate the capsule. If he fires the laser inside the capsule, it can bleed like hell, because the prostatic veins lies over the capsule only. So we have to be very meticulous that we don't go very much inside the prostatic capsule so that it starts bleeding. So you can see the adenoma is being separated and it's being pushed inside the bladder. So I know the surgery is a little bit messy, seeming and all. And this picture is from bipolar TURP, whenever the patient is doesn't want a Holep, or the economically the patient is not viable for a Holep, we offer a standard TURP. I do a bipolar TURP where the current does not, the electrical energy does not go to the bottom of the patient. There is an arc that is called titanium arc. The current goes from the loop and comes from the loop so that it does not go inside. The irrigation used is a normal saline so that we don't have a TUR syndrome. All of us know the TURP of TUR syndrome. We all know this term, but in bipolar TURP, if you resect it for 3 to 4 hours also, the TUR syndrome is not going to happen, because we are using normal saline as an irrigant. We are not using glycine. So whenever we use glycine as an irrigant, that can cause a TUR syndrome, but when you use a normal saline, it won't cause a TUR syndrome. So this is morcellation of the prostate. Whenever the lobes goes inside, you introduce a morcellator through the nephroscope and the adenoma gets stuck into it. So coming to andrology, we do a lot of andrology work over here. So this is a varicose vein, which you can clearly see the dilated and tortuous veins. So whenever we do a varicose vein surgery, we have to take care of two structures, that is vas deferens and testicular artery. At any cost, these two structures should not be damaged, and you dilate and divide all the major veins draining the testis. So this is a very important slide. Any of us males can land up in this complication. That's a penile fracture. That's a rare surgical emergency for us. Patient land to urologist with an eggplant deformity and a pop-up sound while doing sexual intercourse. And when you open up the penis, you see this defect. This defect is in actually tunica albuginea of the penis. The fracture term is actually a misnomer because there is no bone in penis, but the tear in the tunica albuginea, if you don't repair it, the patient will land up in permanent erectile dysfunction. So that's in surgical emergency. There's a time window, 8 to 12 hours, whether we need to treat this patient, and basically we repair this tunica albuginea by non-absorbable sutures and get back the skin to the glands. So these are some of the 3D laparoscopic surgeries which I have done here. One is a lady presented to me with bilateral adrenal glands, enlarged adrenal glands, but the functional workup was normal. There was no increased metanephrines or blood pressure was normal. But in CT, which you can see, there is a large gland over here just above the right side of the upper pole of the kidney. So while doing after doing 3D laparoscopic surgery for that adrenal tumor, so this was the tumor which was very challenging on the upper pole of the kidney. The scar mark is like this. And operating adrenal by open surgery is very difficult. You need to give a very large incision to resect the adrenal. But when the vision is magnified by 3D laparoscopy, the surgery becomes, our job becomes very easy. So we can go into the depth of that, and there is one large vein, adrenal vein, just you have to clip it and remove it. I was very lucky that the patient had a non-functional adrenal, but if the same adrenal would have been a functional tumor, that's a disaster for the surgery. That's a very difficult surgery because whenever you touch the adrenal gland, despite doing everything, BP shoots up like anything. BP shoots up to 240, 260 system. So functional adrenal tumors are very difficult to handle. And the histopathology report of this tumor was myelolipoma. So this is a standard nephrectomy, 3D laparoscopic nephrectomy. This lady was a young lady, 26 years old female. She came with me with episodes of hematuria, and on the left side you could see a large kidney. See, this is the tumor. And 3D laparoscopy surgery did a job for me, and the histopathology report was myelolipoma. So these are some of the cancers which I have told. Now coming to bladder cancer patients present to us with symptoms of hematuria. This is a seems like a very T1 grade, low grade tumor on your left side. The principle is to resect as much as possible and send it for histopathology. Further treatment of bladder cancer depends on the stage and grade of the tumor. Prostate cancer, where the surgical principle is up to a T2 disease. That means if the prostate cancer is limited to the prostate, it has not gone outside the confines of the prostate, preferred modality is always 3D laparoscopic or a robotic prostatectomy. But if the stage has become T3 and T4, they are different modalities of treatment. So our domain ends at, from surgical point of view, at T2 disease, but there are a lot of things, a lot of research going on in treating T3 and T4 disease of the prostate. Because as older men, we have to take care of our prostate whenever we cross the age of 16 years. In Western countries, it is a norm over there to have an annual urological checkup for elder men. So I request you all to ask your patients or educate your patients that whenever your patients cross the age of 60 years, have an annual urological checkup, have an DRE done and an annual PSA done. So out of 100 patients, if you are able to detect 2 or 3 cases of prostate cancer also, that will do a very good justice to our society. Rather than a patient landing at a T4 M1 disease, if we could detect it at T2 disease, the patient would have been cured of his prostate because it's a very slow growing tumor. Kidney cancer, which I have told, it depends, the complexity of the surgery depends on the extent of the kidney cancer. The slide which I have shown, it was a T2 disease, less than 10 centimeter of cancer. But complexity arises in kidney cancer when there is a concomitant renal vein thrombus. Whenever there is a renal vein thrombus, that may extend from suprarenal IVC to infrarenal IVC, then the complexity of the surgery arises. Otherwise, if there is no IVC thrombus or renal vein thrombus, it's a straightforward surgery. Whenever there is a thrombus, you have to clamp the suprarenal and infrarenal veins to remove that thrombus also. Penile cancer and testicular cancer, they are a standard modality of treatment. Whenever we encounter a young guy with a testicular mass, we have to rule out testicular cancer. There are 3 simple blood tests, alpha-fetoprotein, beta-HCG and LDH, that can rule out that the young chap is having a testicular cancer or not. So, welcome to MASH. So this is our team in MASH Hospital. Our center is Mansi Bansal, Manish Bansal, and this is our backbone of the team. So these are some of the testimonials of the patient. The patient which went happy from the hospital after my treatment, and I'm very happy to announce that we are also starting a new MASH hospital in collaboration with Manas Hospital in Sector 34 Noida. So basically here in this center we can treat our patients who are not able to inculcate all the expenses of the surgery, who are having Ayushman card, CGHS card or ESI card, so that we can cater to those patients who have these sort of problems of financial. So, thank you very much.
I think you can lights on. So thank you, Dr. Ankit, for covering almost everything about urology, including endoscopic, laparoscopic surgery, andrology, and even onco-surgery in urology. So one thing he told, and that we should take a lesson, that size of the ureteric stone is not the only criteria for operating on ureteric stone. It depends also on symptoms and also on, I think, ultrasound finding of whether there is hydronephrosis or hydroureter. Because if there is hydronephrosis or hydroureter, then your threshold for size, I think that reduces. What you recommend?
So, ultrasound is the screening modality. Our treatment choice does not depend on the finding of the ultrasound. So, in each and every patient of my stone disease, I prefer to do a plain CT scan to look at actual size of the stone, actual degree of hydronephrosis, and the most important parameter which is not depicted in ultrasound is the perinephric stranding. So I'll just comment on that. If there is a lot of perinephric stranding and the size of the stone is 3 mm, that means that the stone is not going to come out on its own, because perinephric stranding takes around 10 to 15 days to be visible on a CT scan. That means the stone has been there for last 15 days and is not going to come. So our finding does not depend on the ultrasound finding, but it's a screening modality to look whether the patient, symptom of the patient is because of which disease. Actually it's a retroperitoneal disease or an intraperitoneal disease.
My question was, when you do CT scan first time and the patient has 3 mm stone and there is mild hydronephrosis, will you follow up with regular CT scan or can you monitor hydronephrosis by ultrasound only? That was my question.
So I prefer to do a low dose CT scan in single shot, but repeated CT scans are never recommended. To check the degree of hydronephrosis, ultrasound is the investigation of chance, because in our training we used to do our ultrasound. We did not depend on the finding of a radiologist, because we had ultrasound machines in our OPDs, IPDs and in our OTs. Because I'll just share one thing with you guys, that ultrasound is our stethoscope. As Joe's stethoscope is the Whitman, our stethoscope is the ultrasound machine. Because whenever we want to look at the kidneys, we take care of the ultrasound on our own. Because many a number of times I used to do my ultrasound over here also.
That was my point. Size of the stone, we don't rely on ultrasound, we rely on CT scan, but hydronephrosis, follow-up patient, you cannot do repeatedly CT scan, so you can do ultrasound. That was my point. So one thing, when you are doing RIRS, is it more difficult for lower calyx stones than upper calyx stones? RIRS for lower calyx stones, when you have to band your ureteroscope.
So I'll just comment on that. The location of the stone, the difficulty of the surgery arises because our flexible ureteroscope is straight and there is a limitation to a degree which it can bend. So nowadays the recent chip on tip flexible ureteroscope can bend to 270 degrees. 270 degrees means when you are in the pelvis you can reach maximum angle of lower calyx. But the problem arises when we pass the laser fiber. So we don't need to look at the stone, we have to laze it also. So the problem arises whenever we put the laser fiber inside the scope, the degree of flexion of the flexible ureteroscope goes down. It's not 270 degrees, it's 220 degrees. But there is a maneuver to do it. So the recent maneuver that has been published in Chinese journal also, I've done 3 cases, I'm writing my paper on which, that if there is a lower calyceal stone of 1.5 centimeter and you want to do a RIRS on that, what I tend to do is raise the ipsilateral leg to around 40 to 50 degrees. Yes. So because whatever urological surgeries we do is in always lithotomy position. So suppose I am doing RIRS for the left kidney and the stone is lodged in the lower kidneys. It is very difficult for me to angulate my flexible ureteroscope and pass the laser fiber and laze it completely. I could do it for a 5 or 6 mm stone, but for a 1.5 centimeter stone, it becomes very difficult. Then the maneuver is to laze that left leg up to a 50 degree or 70 degrees so that the stone comes out in the pelvis. So,
do you monitor it with the ultrasound?
Sir?
Do you monitor those with the CM?
CM is always there.
CR means the standard. So you said supine. Supine PCNL is welcome because one of my patients recently got denied surgery PCNL because he had some spine problem.
Yes.
I don't know.
Mic is not. Mic is not.
So just one thing I would like to
Sound.
एक mic नहीं
ये साउंड
On करो.
ठीक बोल रहे हैं बा आवाजें बुलंद थोड़ा और तेज बोलो बिना साउंड नहीं बोल रहे हैं
So thank you Dr. Ankit. Just one thing I would like you to tell because it's very common problem BPH and when you like to give alpha blockers when you give you would like to give anti-androgen because we give combination of two also we give either of the two also not in combination either alpha blocker or anti-androgen like dutastride. So when you this is just for because every I think physician is also using this medicine for BPH just 2 lines then we will
So patient usually come to you guys for LUTS, whatever symptoms the patient have because of the prostate. That the umbrella term for that is just speak like that. The umbrella term for that is lower urinary tract symptoms. Now it can arise from the BPH or any other cause. First of all, we have to know that the cause of the lower urinary tract symptoms is BPH. That's called benign prostate hyperplasia, and there is no foci of cancer. Now it depends on the degree of symptoms. Symptoms, how we scale the symptoms. It's on IBSS score. We give a form to the questionnaire to the patient. Whether the patient is having mild, moderate, or serious. I'll just come to that.
Only when you start giving medicine, then when you will choose alpha blockers, when you will choose
So decision on alpha blocker is the go-to first medicine. We start on alpha blockers first to the patient, but if on ultrasound the size of the prostate is more than 40 grams, we give dutastride. Dutastride is 5-alpha reductase inhibitors. We are not, that's not for anti-androgen basically, that blocks the production of 5-alpha testosterone. So that when the size of the prostate has crossed 40 cc, it's always better to combine alpha blockers with latest trial. And in cardiac patients, suppose the patient has got multiple comorbidities with cardiac issues, we prefer to give the molecule called silodosin. Silodosin is preferred over tamsulosin in cardiac patients, but if the patient has got no comorbidities, the tamsulosin is bothering molecule.
And albuterol for those who are concerned about retrograde ejaculation. Because the incidence of retrograde ejaculation is minimal in albuterol.
Yes. So in some patients who are very sexually active, the preferred molecule is
Albuterol has alpha block. Thank you, Dr. Ankit. Now Dr. Johan.
Dr. Ankit, wonderful presentation, and we never knew that you are doing such wonderful work. So you actually showcase the entire thing that you are doing here in this wonderful facility. I wanted to know, do you have holmium laser here?
Yes, sir.
So you have holmium laser, and you are doing your prostate surgeries with holmium laser?
Yes, sir.
I mean, by default, all of them?
No, not all of them. Suppose the patient has got some constraint in financial, because there is a cost associated with holmium laser, because the fiber which, the 550 micron fiber, if I am doing a 120 cc with that holmium laser, the fiber degrades to half in that case. So there is a cost associated with it. Whenever we have a constraint about the cost, I explain to my patient, these are the two modalities, bipolar TUR or a HOGAP. So which one you want? The end result of both are same. The end result is not different. But nowadays patient demands that I need to get my prostate removed by laser only. So if the patient tells me, no sir, I want to get it done by the HOGAP, but by default it's HOGAP.
Alright. I wanted to ask you if you have a prostate size of about, let's say, more than 100.
Yes.
Do you plan a stage surgery or you do it in one sitting?
Stage surgery are the thing of the past. Nowadays, I can, with the holmium laser in my case, I can do up to 200 cc of the prostate in holmium. So that's not an issue.
Alright. As they say, Dr. Ankit, all that glitters is not gold. So even if you use holmium, there are issues.
Yes.
And when you do a 200 gram prostate, which you just said, it is a long surgery. So the exposure to the laser is that much longer. And therefore, there are chances that the injury to the surrounding tissue will be much more. And therefore, there will be resultant strictures. Sir, your experience with resultant strictures after holmium laser in your setup?
So I'll just come to that point, sir. Strictures are not because of the laser firing in the prostatic fossa. Because by laser, what I'm trying to do, I'm trying to enucleate the prostate in the prostatic fossa, which is always wrong. The stricture which happens in bipolar TUR or a monopolar TUR because of lack of lubrication and current going inside the sheath. How do you gain access to the prostate? There is a 24 French continuous flow sheath, metal sheath, that gains access to the prostatic fossa. Now we pass the laser fiber, it's a 550 micron fiber, to just enucleate the prostate in hollow. The stricture does not occur because of this. The stricture occurs where there is a forceful entry of this continuous sheath. Whenever we force it inside the urethra, stricture occurs because of it. It does not occur because of hollow. But one side effect of hollow, I will come to that, is what's been seen is around 20 to 25% of patients have dysuria after hollow. But that depends on the learning curve of the surgeon. If the surgeon is experienced, he has done 60-70 cases of hollow, the incidence of dysuria is less, around 5 to 6%. But in bipolar TUR, dysuria is not there post-surgery. But when you compare both the procedures, when you see post-op ultrasound, there is always some of the prostate left in bipolar TUR as compared to both.
You mentioned about a procedure called RI-RS in your setup. I wanted to know what is the average cost of RI-RS in your setup.
So it depends on the size of the stone also, and depends on the TPA, which TPA it is. but the cost is around, I'll say 90,000 to a lakh rupees.
So I'd like to answer that. So coming to most of the cash patients here, and Bhaskar knows it, so wherever there are financial restraints, like some patients were come with practically not even 50% of what we could, offer, no patient is going back. That's the motto.
That's right.
So,
And that is Hanish
Yes.
always there to take care of.
I think also that I have operated here Lapcoli in 45,000, which is not possible in any
So we did-
substandard hospital also.
so we did yesterday, I did a lab perforated appendixectomy with the 3D, which is 35,000 because he didn't have anything else. So we are not sending anybody back for the lack of any finances. We want them to utilize it. Maybe it's a selfish motive that it will grow organically, that he will refer more patients to us. But as of now, we're not sending anybody.
I must say that is the right strategy. That is the right strategy. Because you only grow by helping, other people,
Yes.
by helping other people. And if you give a confidence to the community, who come to the setup, that no matter what, we are there to help you. Okay, it's not an institution or a place where only money is being made, but cure is being offered, and at a rate which your patient can afford, at times cannot afford. We are there to support you.
We are.
I think it will go a long way in putting your place on release map, if I can put it that way. I give it to the.
Just one question. I know you are not doing robotic prostatectomy for benign. I heard one urologist recently, he is ex-army, now operating in one of the centers in Dwarka. I heard first time that he is doing robotic prostatectomy for benign, because robotic prostatectomy is very good for
Malignancy.
malignant
don't need a biopsy.
cancer prostate, but he is doing for benign prostate also. So do you think any reasoning or
I'll just explain it, sir. Most of us, when we are internship, have seen how the prostate is enucleated. The principle is same. You go inside the bladder, you just enucleate it with fingers, and the prostate is off. Now, in BPH, when the size of the prostate grows to 250-300 cc, it becomes very difficult in a whole, because the duration of surgery will be enlarged. Now the same thing can be done robotically. You just give a transverse incision into the bladder, gain access to the prostate, and enucleate whole of the prostate into it.
so robotic prostatectomy for benign disease is actually replica of what we were doing purely
Yes.
open surgery.
Yes.
That is exactly the replica of that. Thank you.
And sir, that surgery is not limited by robot. I have done 2 prostatectomies for a simple prostate, the size of the prostate being very large, laparoscopy.
Yeah.
So robotic is just a way to gain access to the organ. Both the surgeries can be done by a laparoscopic approach or
No, I know it's not very popular, but just I heard few days back by, I will not name because it's not fair, but he is in Delhi and he is ex-army person. So, doctor, yes.
Dr. Poddar sir mentioned about a lap chole, which he did for about 40-45. If we have actually a very poor patient, can we dare to send a patient for about 40-45 here for a lap chole here?
I'll just come to that, because we have given complete liberty.
On behalf of everyone.
So we have given we have been given complete liberty by Hanish Bansal sir, that you don't need to worry about the cost. You just do the whatever right is for the patient. So my motto to join him was that only, and that was pre-discussed before inception of the
Sir, it has to be accessible and affordable for all the patients.
So costs will
That is
never
our
be the limiting factor
mantra.
for your patients. Don't
And
worry about
even
it.
at 35,000 or 45,000 rupees, we will still go ahead with 3D laparoscopy that Dr. Sachin does or Dr.
Don't worry about that, never.
Or even Dr. Rashmi for that matter.
Harish, I must congratulate you for the attitude that you have, because it will go a long way.
Thank you, sir.
And I must say that we have surgeons here. We have Dr. Poddar,
Yes.
and we have Dr. Vipender Sabharwal, who runs a very big show himself. And they would understand the limitations of, the cost versus the surgery versus the benefits that. So the kind of setup that you have produced and the kind of facilities that you are offering, I would only request you that please don't save us for a rainy day. Call us when it is not so rainy.
Let me begin by saying, Dr. Ankit, that was a wonderful talk.
Not right now,
As-
but our Noida
Noida
center
Center is registered for CGHS.
is under CGHS and IL.
So after that PCNL and ECIRS,
Sector 34.
let's talk a Hanish, you're interrupting my questions. Let's talk a little after the PCNL and the ECRS. Let's talk a little about the urological cancers. So our commonest would be what? CA prostate, or is it the CA urethral, or the bladder cancer, followed by the renal cancer, which is commonest in India.
Prostate.
So with the new
Is it
awareness in our
prostate or the
society,
bladder cancer?
it would be definitely CA prostate.
CA prostate.
But with new awareness and routine checkup of PSA and screening of the patient, the incidence of prostate cancer is also going to go very high. Because a lot of prostate cancers does go undetected. We see a lot of prostate cancers in a very late stage, which is not the norm in Western countries. In Western countries, when you see the most common type of cancer after lung is prostate.
Annual PLC.
Yes. So that's what I requested in your practice. If you encounter a patient more than 60 years of age, do ask him to do a routine checkup for annual PSA. That's it.
So, talking about CA prostate, some recent biomarkers, apart from PSA, would you say the PHI or the parametric MRIs are diagnostic for more accuracy and follow-up? I am talking about the PHI and the multi-parametric MRIs.
So full form of PHI would be a prostatic health index. It combines three molecules, that is HK2 and fractional serum PSA. It's a biochemical marker. Better accuracy than serum PSA, but it has an added cost. It's available in our country, but the cost is around 30-40,000, which same thing can be done with a 500 rupees test that's called serum PSA. We do multi-parametric MRI, that's a radiological investigation. When there is a doubt that the patient might harbor a CA prostate. The multi-parametric MRI was introduced to avoid unnecessary biopsies. Suppose you have a patient whose PSA range falls between 6 to 7. On DRE there are no nodules. Now you are in dilemma whether this patient might have a CA prostate or not. Earlier, without invent of multiparametric MRI, the routine care would be to subject that patient to a prostatic biopsy, so thrust-guided prostatic biopsy. But with invent of multiparametric MRI, we grade those nodules or lesions on a category of 1 to 5. Lakett scale of 1 to 5, that is called Peerage score. Peerage 1, 2, 3, 4, 5. Whenever you have a patient with a Peerage 4 or 5 score, the finding of a significant prostatic cancer goes high. It's around 70 to 75%. Peerage 1, 2, you don't need to do biopsy of the prostate. So that you have avoided around 25 to 30% of the prostatic biopsies, because that's an invasive thing. Peerage 3 is an equivocal disease. You have to correlate with the history, with the DRE of the patient. If the patient has a significant family history, suppose the patient, his father has a prostate cancer, his first degree relative has got a prostate cancer, then definitely you need to do biopsy that prostate.
Sir, and role of PET?
PET CT comes after that, sir. First, we do biopsy to detect the Gleason score of the disease. So PET CT comes after that to do the staging of the cancer. First, we diagnose what is the aggressiveness of the disease. That is dependent on the Gleason score. So if the Gleason is 3 plus 3, that means that is a very less aggressive disease. You don't need to operate on that patient. If the life expectancy is more than 10 to 15 years, Gleason is 3 plus 3, just put that patient on active surveillance. For 6 months, for 9 months, you regularly observe that patient.
But if you have diagnosed prostate cancer Instead of doing bone scan, CT abdomen, you can directly do PT, PET scan, and then no need of bone scan and CT abdomen.
I'll just come to that. When we have diagnosed,
Let me complete, no? Okay.
Yeah.
Now you answer his question, then I'll proceed further.
so sir, bone scan was done previously. The cost of the bone scan is around 4.5 to 5,000 rupees, but the sensitivity of the bone scan of finding a significant prostate cancer is low as compared to PSMA PET CT. The actual term for that CT is a PSMA PET CT. So whatever malignant tissues we have outside of the prostate, they express a molecule called PSMA, and when we give a ligand, PSMA ligand, that gets attached to those cells so that it can be detected in a PSMA PET CT scan.
So let me proceed further. And the American Society of Clinical Oncology talked about more accurate, which is more accurate? Is it the prostate biopsy or the MP-MRI? And they said 93% accuracy seen with MP-MRI as compared to 48% with the biopsies. So this was also published in NAGM. More than 12,000 patients. So MP-MRI, this is what a multi-parametric MRI is more diagnostic in, as compared to biopsies. So biopsies we thought is the gold standard here. It's no longer there. So it is the multi-purpose or multi-parameter MRI which is today the gold standard in diagnosing CA prostate. Dr. Parashar talked about PSMA, PET scan. So it's a prostate-specific membrane antigen for imaging prostate for precise detection and can identify cancers missed by our current, imaging.
Yes.
So the PSMA scan is talking about, so that's so good. I'd finally like to
Let him clarify. Each biopsy negative patient and who is
Let's answer that question first.
each question. If biopsy negative and if on MRI it says that it is malignant, will you start?
I'll just
treatment?
come to that.
that is the treatment.
If the patient has got a Pirax 5 lesion on multi-parametric MRI, suppose you have got a patient whose PSA is 10, percentage free PSA is less than 10%, and multi-parametric MRI suggests Pirax 5 score. But I cannot treat that patient without biopsy.
That's what
I need to have a histological proof. I need to have histological proof whether this patient is having a CA prostate or not. Otherwise, that patient can sue me in the court. Doc, I don't think I have a CA prostate. You just did an MP-MRI, which is suggestive of Pirax 5 lesion. There are 3 to 4% chances that a Pirax 5 lesion can be non-cancerous. So I am having no cancer. You remove my prostate, now you land up in court. So that the principle of doing a biopsy is to prove that there is a definitive prostatic cancer with the patient. And now the treatment depends on that.
So I would like to add on to that question, sir, as you would ask. Point number one, any Western study has got a setup for most of the candidates to acquire that. How many of our people would actually go for a MPA MRI which is going to be so costly vis-a-vis a biopsy? And any oncology, the bottom line is we need to have histopath in our hand to continue with any kind of intervention, not just radiology. So imaging is a part and parcel of a diagnostic tool, but histopath is the confirmatory process to go ahead with any surgical intervention.
I will just interrupt the master for a second. Do we have enough CT and
So we're
MRI?
getting the CT done, it's getting prepared right now. So we'll be getting a CT in 1.5 months.
And MRI?
Not an MRI, just a CT scan. CT scan, sir.
Okay.
So after every prostate which is being removed, you do histopathology?
Definitely. Whatever tissue is removed from the body, we send it for histopathology. Even the stone. So that's my routine practice. Whenever I raise the stone, I try to retrieve a fragment of the stone to send it for chemical analysis. So that that patient doesn't land up in another episode of hospital. And I can advise him accordingly what diet I should take. That's a routine in my.
Dr. Kalra.
finally, so my last
Question.
interesting case, and that would be regarding, 81-year-old man admitted with worsening mental status, had multiple comorbidities like Alzheimer's, congestive heart failure, hypertension, BPH, and recurrent UTIs. He was tachycardic, he was hypotensive with a systolic blood pressure of just 80, and he was hypoxic. Ultrasound revealed 700 ml of urine with an enlarged prostate.
700 ml of urine in bladder.
700 ml in his
Residual
bladder,
Residual.
and 275 cc was the weight of the enlarged prostate. So he had significant leukocytosis, AKI, pyuria, admitted with a diagnosis of acute septic encephalopathy secondary to UTI, and acute hypoxic respiratory failure secondary to CAP. What is CAP? Community acquired pneumonias. So, and a PSA of 1398. How high is that, friends? And which is the highest PSA recorded till today? Anybody?
It can be at
10,000.
1,000 minutes. 1,000.
1,000?
No, I have seen more than 2,000, 3,000.
29,000.
Yeah, I have seen 3,000.
That's the record.
I have seen 3,000.
So, Dr. Poddar, beyond what you think, it's not 3,000.
No, I have not said you cannot.
Okay.
But come to the point.
So it is, much more than what we think. Not only what Dr. Poddar thinks, what we think. So this was 1398 PSA. And friends, would you believe? Biopsy done, truss guided biopsy done, revealed acute and chronic inflammation with focal necrosis. So he was of course given meropenem for his septic sepsis, and he recovered very well, and his PSAs then regressed. So this is an eye-catching case. One, you see how it's very 275 cc prostate and a PSA so high. So 1398 PSA. This was because of acute prostatitis.
What was the age of the patient?
81 years old, I said.
So I don't think here.
With a recurrent
Just one thing,
UTI.
I don't think here biopsy was required. You should have simply treated patient as septicemic patient. No biopsy was required here.
I thought
Why
you were going
biopsy?
to ask me differentials about it.
Let me complete.
Sir, please.
Why
I
biopsy?
agree. You agree with me?
Why biopsy was done? Because of he was referred to a urologist like you or like him, and they said let's do a biopsy to prove, because of the high, very high. No, this much high PSA is never seen.
This much high.
So maybe the
Have you seen?
Is usually due to infection, not due to malignancy.
Have you seen a PSA
Yes, due to infection, not due to malignancy.
So high?
Yes.
They all teach us, sir. Keep on
But
taking
anyway.
lessons.
I'll just
I will take his
solve
opinion and
all of
find
your
out.
problems by doing just a simple test.
Yes.
That is digital record
I agree with him totally.
Sir, please listen to me.
In this case, no
If,
biopsy was
if
required.
the PSA is so high, patient
I
is
would have
so-
gone for a multiparametric parametric.
Why?
because
MRI.
I'll just come to that. Because
No biopsy was needed here.
Why multi-parameter? No, nothing was required.
Because this is the modality of choice today.
Sir,
It is diagnosing CA cancer.
so what happens
Go ahead.
when you have, let's
No,
put
it
very,
was not
very,
required.
one second, sir. When you have such an elderly gentleman, as Sir said, Parkinsonism, this and Falana and
No,
everything.
I didn't say Alzheimer's.
Alzheimer's. So, point number one, the patient may be bedridden, not very mobile. Most
And
common,
a history of recurrent UTIs.
so the most common thing is hygiene. They would have phimosis, they would have melanopostitis, which can lead to these kind of things. So the most what he said, I also concur. The most important thing is a physical digital rectal examination.
It was done.
When you find bogginess, when you find that
It was
prostate boggy,
Yes, it
you
was.
know it is
Then
prostate.
you don't need
Then you don't need to go back.
Absolutely.
You need to drain that pus.
What I was stressing was that you could have a high PSA, you don't have to have a CA prostate, but high PSA. Thank you, sir.
Dr. Kata sir, friends, we had a day where it was difficult to get 15, 16 people for the CME. We have 35 people for the CME. I think we'll give it big round of applause to MASSH and to Mr. Harish Bansal and to the wonderful medical fraternity of this hospital. We will come to Dr. ML Kalra sir, and our question answer session will end here.
And Dr. Kalra, we will give time in next session, just one question.
सर मैं सवाल तो पूछ नहीं रहा पता नहीं मेरी आवाज आ रही है सर मेरी आवाज आ रही है कर तो दिया
ऐसे बोलो
कोई बात नहीं
फिर क्या हुआ?
मैं झुमका गिरा रहे नहीं कहने वाला हूँ सर डियर फ्रेंड्स मुझे बहुत अच्छा लगा
Final question.
शर्मा जी बैठो 2 मिनट बाकी है.
हेलो हाँ जी सर मैं ये कहना चाह रहा था कि मुझे अभी बैठे बैठे पता लगा कि MASSH का मतलब मिनिमल एक्सेस है सर्जन के लिए और मैक्सिमल एक्सेस है पेशेंट के लिए. वेरी गुड.
क्या बात है. कभी ये कभी भी है
सर मेरा छोटा सा सवाल ये था जाते जाते सर हम बहुत इम्पोर्टेंट सवाल जो इन्होंने भी आधा पूछा था. we use at times Tadalafil, Tamsulosin and dutacetride and Silodal. So what are the parameters when we select? There are at least 5 of them.
So suppose you have got an index patient who is 55 years old, sexually active, and he has come to you for WGS. You did all the tests, the diagnosis was BPH, and patient wants a very good sexual life. Okay? So start that patient on Tamsulosin, 0.4 milligrams bedtime. Nowadays there are a lot of studies which indicate that Tadalafil low dose, 5 milligrams, is also very beneficial to those sexually active patients when combined with alpha. But you have to take care of that effect of hypotension on that, so that the patient takes those medicines at time. And you got second patient who is not sexually active, not bothered about his function. You can start that patient on Silodus, who has got multiple comorbidities, because it's a very cardioselective drug and safe for cardiac patients. So low dose Tadalafil is also come in a very big way. That 5 milligram or 2.5 is going to come. So start those patients on 2.5 or 5 milligram low dose daily Tadalafil for 3 months. That would prove wonders for the patient.
What about alfucizine with finasteride?
So if I'm combining I don't use finasteride first of all. I use dutacetride only, because that's more selective.
Alfucizine D is available?
Yes, it's available. Pharma companies will make all the combinations.
So, do you recommend that?
I don't use it.
No?
Alfuzosin is I recommend in those patients who are very much bothered